the University of Maryland Department of Neurosurgery on, and Dr. Charlie Sansur is going to take the lead. And we're having a very interesting topic today, anterior release of the thoracolumbar spine from posterior approaches. Dr. Sansur and colleagues, good morning from Seattle. Lead us along.
All right. Well, thank you very much, Dr. Chapman. It's great to be able to participate and an honor to be able to present along with all of you. So we're going to discuss a controversial topic, but something that we have been exploring here at the University of Maryland, both in the Department of Neurosurgery as well as the Department of Orthopedic Surgery. We're going to discuss the anterior release of the lumbar spine from the posterior approach. So let me go through these. These are my disclosures.
We need you to share your screen first, Dr. Sansur.
Oh, sorry. I thought I already was sharing. Okay, everyone can see my.
Yes, your slides are visible.
Okay.
If you could go into presentation mode, Dr. Sansur, that would be great. Yeah, we just need you to go into presentation mode.
Okay.
So on your slide thing, bottom. All right, almost. So there's a large on the bottom white panel on your PowerPoint. Yeah, there you are. We see you well.
Great.
Let me go back. Okay, so all right, so back to the beginning. So anterior release from the posterior approach, potentially controversial topic, but something that we've been exploring here at the University of Maryland. Both myself and Dr. Stephen Ludwig, we share this common interest, and we've been working together to basically present these cases and understand it better. These are my disclosures. So the release of the anterior longitudinal ligament is a very powerful tool. And most commonly, it's performed during anterior approaches, as that's the area where it is most easily accessed. On occasion, the anterior longitudinal ligament is released during a lateral approach, and is not unusual to have that described in the lateral-based procedures such as XLIF and DLIF and OLIF. Sometimes, inadvertently, the anterior longitudinal ligament can be released during a posterior approach, and so we can learn from these inadvertent situations that sometimes you can intentionally release it from the posterior approach. Regardless of what approach is used to release the anterior longitudinal ligament, when it's achieved, the results can be very similar to a 3-column osteotomy. So releasing the anterior longitudinal ligament from the posterior approach is far from a novel concept. It was actually described in 1945 by Dr. Marius Smith-Peterson in the Journal of Bone and Joint Surgery in 1945. If you backtrack and look at the history of Dr. Smith-Peterson, he actually trained at at Harvard and worked with Harvey Cushing for a portion of his training, and so you can see the close connection between orthopedics and neurosurgery even back then. This figure depicts an article from 2008 in the Neurosurgery Focus, and this is an article that I published. Dr. Oskulian is actually a co-author on this, where you can see the original description of the Smith-Peterson osteotomy was one in which the posterior elements were resected, and when compression was performed across the posterior segments, the anterior longitudinal ligament essentially was cracked, and you have an anterior lengthening procedure. So this is in contrast to the Smith-Peterson osteotomy, where the anterior column remains constant. So the Smith-Peterson, as it was initially described, was an anterior column lengthening procedure. I think that's an important point, because nowadays when we use the term Smith-Peterson osteotomy colloquially, it very often is just a small posterior column osteotomy without necessarily lengthening of the anterior column, and it's sort of lost a little bit of its original definition over the years.
Hey, Charlie, a question by Dr. Balk. He just wanted to make sure that there's a definition. So anterior release implies more than just doing a discectomy. It means that the anterior longitudinal ligament is actually physically separated. Just to clarify, is that correct?
Yes, it's physically separated or attenuated, and we'll discuss these nuances soon.
Thank you.
So the anterior longitudinal ligament release, it can be partial or complete. And when patients have a fixed sagittal plane deformity, such as in the case of ankylosing spondylitis, the ALL is often calcified. And in these circumstances, the anterior column can potentially crack during a standard PSO or 3-column osteotomy. And this is the reason why a provisional rod is necessary, because sometimes it can crack in an uncontrolled way and significant translation can occur. For patients that do not have a fixed sagittal plane deformity, and for patients in which the ALL is not calcified, the disc space may be potentially collapsed, and you can attenuate or stretch the ALL in order to get a larger cage into the disc space without actually violating the ALL completely, but just stretching it. So you have the ability to partially disrupt the ligament and stretch the anterior column. The technique that we have been utilizing is the performance of wide facetectomies bilaterally with thorough discectomies bilaterally, and the placement of blunt paddle dilators. And depending upon whether the disc space is calcified or whether the anterior longitudinal ligament is calcified, it will either turn into a stretch or a crack. For patients who have non-calcified anterior longitudinal ligaments, we resort to essentially a stretching of the ALL and a gradual dilatation of the anterior column. And we sequentially put in bilateral paddle dilators and gradually release and stretch the ALL. If the need for substantial correction is present, you can sequentially dilate the ALL to the point where it actually stretches to the point where it snaps and is completely released. But we generally aim to dilate it for patients who have intact ALLs. This is an example where you can appreciate prior to the intervention that we performed, you can appreciate a sclerotic end plate right here. In this, whenever you see a sclerotic end plate like this, it really gives you the latitude to aggressively use those blunt paddle dilators to significantly stretch open the anterior column. And this was done at 2 levels, and you can appreciate a stretch of that anterior column and a good ability to get anterior column height without necessarily shortening the posterior column. Here's another example of a bone-on-bone kyphotic segment that was successfully stretched without actually violating the ALL. And you know, in that situation, you can put in a cage without the fear of the cage migrating.
Charlie, this sounds a lot like the Chapman-Esculian intradiscal osteotomy.
Yes, it is. It's basically, I think the point of the talk is to say that there's a broad spectrum of what one can do. You can attenuate the ALL and weaken it and stretch it, and that will give you the latitude to put in a cage, or you can disrupt it and really get an aggressive correction. In this case, this patient had a violation of the ALL during surgery, and for that reason, we did not end up putting cages in, but we were able to mobilize those interspaces in order to get a substantial improvement of the alignment. Depicted here is a patient who has had a previous surgery with a calcified ALL, and in this case, the ALL was essentially cracked, and that allowed the correction to be achieved without doing a full pedicle subtraction osteotomy. This allowed for a substantial release of the ALL and correction. This is a 24-month post-op showing maintenance of the alignment, and this just shows the pre versus post. This is another patient who had the need for improved lordosis, and she initially was consented for a pedicle subtraction osteotomy, but instead we were able to get a good mobilization of that disc space, and we were able to get a 17-degree correction from stretching of that ALL, similar to the intradiscal osteotomy that you were describing. So depicted here is, you know, the 1 degree of lordosis pre-op and 17 degrees of lordosis post-op. So, you know, the benefits of this method is that there's less blood loss than a standard PSO. Because you're lengthening the anterior column as opposed to shortening the posterior column, there's less kinking of the dura. Because there's less kinking of the posterior elements, the standard concern of inadvertently compressing the nerve roots is diminished during the standard PSO. If you're removing less bone, you're having a better opportunity for better arthrodesis.
Hey, Charlie, just really quick. This is Rod. Great presentation. Can you just go over, because I think this is important for the fellows and the people watching this and other attending, go through the steps of how you put a rod in and release.
Sure. So basically, you know, I'm going to go back to one of these slides over here. Essentially, what happens is once you have your fixation, a temporary rod is placed prior to doing your aggressive discectomy, and once you are at the level of the ALL, we take a blunt dilator and place it on one side and then turn it vertically. And then you sequentially do that bilaterally, sequentially doing larger and larger paddle dilators on both sides. And these are blunt instruments. So when they, when you do pass through the ALL, it will either just gently dilate the ALL or break it. But it's important at all points to have a temporary rod in place so that you don't get translation. Sometimes you don't go through the ALL and you just simply stretch the ALL, and once you've been able to dilate enough, as in this case, we didn't have to go through the ALL. It just simply dilated it, and we were able to put a cage without the fear of it migrating. In a case like this, where the ALL was completely released, the temporary rods are very crucial to avoid the translation that can happen. And you can get a preliminary idea about whether or not the ALL will crack versus stretch based on what the pre-op CT looks like. So, the the surgery is not without risk, because we are releasing the ALL with a blunt dilator, and it's with fluoroscopic visualization and not necessarily direct visualization. So if sharp instruments are used, it's at risk of injury to the great vessels, and that's why we only attenuate it and attenuate the ALL with blunt dilators. And if it does crack, as would be the case for a calcified ALL, a cage is often not possible or maybe not recommended because the cage is at risk for anterior migration. So, I'm going to now pass this on to Dr. Nathan Hahn, who will present a paper that was recently published in the European Spine Journal on this topic.
All right, thank you, Dr. Sansur. I'm going to proceed to share my screen. If you can unshare your screen, Dr. Sansur.
Yes.
I can. Everybody see the screen okay?
Yes.
Yeah.
Okay, this is our recent paper published in our institution. It's a single center retrospective case series of a relatively small number of patients, 11 patients, who underwent this posterior approach to ALL release in conjunction with the posterior column osteotomy, with or without interbody for deformity correction. We identified 11 patients whom Dr. Sansur and Dr. Ludwig, our senior surgeons, performed this AL release with PCO from years 2010 to 2019. Electronic medical records were reviewed for demographic, intraoperative, postoperative, and complication data. Pre- and post-operative scoliosis x-rays were used to measure radiographic parameters, And the relative contribution of the ALL release level to the overall lumbar lordotic correction was obtained by taking the ratio of the segmental lordotic correction at that level to the overall lumbar lordosis correction. And in cases where standing scoliosis x-rays were not available, in 2 cases, CT scans were used. And 2 independent measurements of the parameters were obtained, and average of the measurements were presented in the paper. I'm not going to belabor too much into surgical technique, as Dr. Sansur went over in pretty good detail, but basic standard exposure to expose the bilateral facets, pars, and transverse process. Pedicle screws first placed and temporary rods placed. The disc-based distractors were used as Dr. Sansur described with the sequential dilation and advancement of that blunt dilator ventrally until it crosses the anterior surface of the vertebral body, leading to partial opening of the ALL. And by turning that dilator 90 degrees, you can further stretch and release the ALL. And once that is done, we can use temporary rods and the pedicle screws to use a cantilever technique to develop our lordosis. And in cases with partially intact ALL with adequate end plate bone quality, interbody can be placed. And the disc-based distractors are then removed and the remainder of surgical procedure completed. This is our data of the demographics and the patient characteristics. Just highlighting a few aspects of the paper. Most of our patients in our series were prior lumbar surgery patients who already had lumbar fusions. And in the levels that the ALL release was most commonly performed was at L1-2 and L2-3. And on average, 9 levels of the patient's spine was fused, with the lumbar lordotic correction of 28.6 plus minus 20, and the segmental correction at the ALL release level to about 17 plus minus 12 degrees. And the percentage of correction from the ALL release level contribution was around 49% plus minus 30. There were no hardware loosening complications, no decline in neurological symptoms, but there were 2 revisions in patients 3 and patients 8, which were not related to the ALL release. One patient had a fall and had a worsening radiculopathy requiring a revision for amyotomy. And the other patient had an infection and osteomyelitis that needed a 2-level corpectomy, but both unrelated to the ALL release level. This is the radiographic parameter data obtained from the 11 patients with 14 different ALL release levels. The marks that are highlighted in red are the correction from ALL release after interbody placement, those with the partial ALL release. And the sample size is too small to do a significant statistical analysis, but on average, those levels with the interbody were able to provide a more increase in the correction of the ALL release level. This is one of the example patients in our paper that we presented. So a 70-year-old who had an L4 to S1 prior fusion with adjacent proximal junctional kyphosis and flat back syndrome with a disc space collapse. In this case, we were able to do an ALL partial release and an introduction of inner body at both L1-2 and L2-3, resulting in a segmental correction from 1 to 21 degrees and 3 to 12 degrees. The limitation of the study is that it is a retrospective review of relatively few patients, and that 2 cases did not have a standing scoliosis x-ray, and the CT scans were used instead. And 1 patient was lost to follow-up after 18 days, which was unfortunate. But as Dr. Sansur mentioned, the anterior column release through this posterior approach to the ALL release can provide adequate deformity correction without subjecting the patient to a more invasive 3-column osteotomy. And our approach to the sequential dilation and opening of the ALL with the blunt dilator was sufficient to induce this 3-column release for increased spinal mobility to allow a greater lordotic correction at that level. And the posterior-only approach allows a single position surgery instead of stage approach, limiting operative time and blood loss and other neurologic complications that could occur with other approaches. The next paper that I want to discuss is a paper by Boll and associates from Barrow, who published the cadaveric study in 2018, studying this posterior open wedge discectomy and anterior longitudinal ligament release, which was similar to what we discussed earlier. They had 2 cadavers that were dissected, one to kind of demonstrate the anatomy that was relevant to their approach, and the second one to assess the parameters of the lordotic correction from L1 to L4 with this power approach. They measured the end plate angle change and the anterior and posterior intervertebral disc height change in 3 different groups. One was just posterior column compression alone. The second group was after grade 2 osteotomies. And the third after this posterior open wedge discectomy and the AL release. They describe both an indirect and a direct approach. The indirect approach is similar to what we have performed, where they do a complete discectomy, and using successfully large paddle distractors, they're able to sequentially distract the intervertebral disc space until they have an ALL rupture. And they place inner body with desired lordotic correction after compression of the pedicle screws. Then they also describe more of a direct approach where they do the same discectomy as the indirect approach, but they're able to dissect the quadratus lumborum off of the transverse process so that you can dissect through the retroperitoneal space to place a blunt curved dissector passing ventral to the ALL to have a protection of the ALL from great vessels. And then with direct vision, they're able to incise this ALL with direct visualization in a 50% ipsilateral way. And then they can repeat this process on the contralateral side for a full direct release of the ALL. And after which they can use this sequential distraction to obtain that lordotic correction. This was a figure kind of demonstrating this direct approach, where the white arrow here is the transverse process and where the quadratus lumborum attaches to it. And once you dissect that off, you can see the lateral part of the disc space, and they're able to place a blunt dissector anterior to this ALL ligament and the disc space for protection. And under direct visualization, they were able to incise this ALL and repeat that for the same method in the opposite side. And once with this complete release of ALL with the scalpel, then they're able to sequentially dilate and further separate that anterior column. So using these methods, they generate this figure and table. The figure demonstrating the lordotic degree change in L1-2, L2-3, and L3-4 levels at the baseline without osteotomy, with osteotomy, and with this AL release. And you can see that in all 3 levels, there were much higher degree of lordotic correction in the AL release level. And the anterior disc height as such correlates with this increase in lordotic correction with increase in anterior disc height and a decrease in posterior disc height. And this table shows the numerical data associated with this figure. And the figure highlighted in red is the AL release components. You can definitely see that L1-2 had the greatest amount of lordotic correction with the greatest change in the anterior disc height increase with the posterior disc height decrease. And these were all values that were normalized to the superior vertebral body on the one level above in order to make the measurements more consistent in different fluoroscopic images. So from this, their group concluded that ALL release from a posterior open wedge approach is feasible and effective in correcting sagittal deformity with allowing lordotic correction as high as 38 degrees to be achieved. And that this technique can provide an alternative to 3-column osteotomy as we described before. And in this case, they emphasize that the end plate integrity is critical with the success of this technique, as you have to put a large distracting force in order to disrupt or rupture the ALL. And in cases where too much force is needed, they recommend doing a direct incision of the ALL with that, protecting the ALL with the blunt instrument to allow reduction of the necessary force transfer to those end plates. And they recommended that clinical experience with this technique is warranted. And the last paper I want to introduce was the paper by, paper by Sweet. And this was a retrospective case series of 47 consecutive patients with fixed sagittal imbalance or segmental kyphosis treated by a single surgeon with single-level transforaminal anterior release with interbody to create an open wedge correction. and they had a radiographic and clinical follow-up of minimum of 2 years. And this is the approach that I think one of the participants were describing, using a curette to release the ALL. So a total of 63 consecutive patients were assessed from 2006 to 2012, and 47 of them were included in the study who had a 2-year follow-up. The decision to perform this anti-release approach was made by those who were deemed not to have adequate correction with the conventional in situ techniques. And the exclusion criteria included those with previous retroperitoneal exposure due to concern for potential vascular injuries. And they also mentioned that this anti-release was not applicable to levels with anterior fusions. This was their surgical technique, standard subperiosteal posterior approach to the spine, placement of the pedicle screws, placement of the harm spreader to distract across the lumbar interdisc interval, and performing, in this case, a unilateral facetectomy to expose the lateral recess and exiting nerve root. And they were able to place a temporary stabilizing rod on the opposite side before a complete annular resection of the disc to prevent that unexpected translation of the vertebral bodies once the disc is resected. And the lateral annulus was released from the collar vertebral body as demonstrated here. And then they were able to use a forward angled curette to dissect the annulus off of the anterior part of the vertebral body, and also in the contralateral part of the vertebral body as well. And once this annular release was complete, they were able to use the in situ rod contouring to produce how much correction that they wanted. And they were able to put interbody cages in the posterior 1/3 of the disc space, with final rod compression performed after that. The results in the fixed sagittal imbalance group and the segmental kyphosis group is presented here. On average, they were able to obtain a sagittal correction of 36.5 degrees and a coronal correction of 32.8 degrees, improving the sagittal vertical axis from 14.4 to 0.75 centimeters. Similar to ours, they had a similar fusion level of around 9.2 with a 700 cc EBL. In the segmental kyphosis group, they were able to obtain a sagittal correction of around 23 degrees with the average fusion levels of 2.8. And from their set of 47 patients, only 3 patients developed PJK, have 4 duotomies, and 4 pseudoarthrosis. And importantly, they encountered no vascular injuries in their case series. And they concluded that this transforaminal anterior release had a comparable correction with pedicle subtraction osteotomy with lower blood loss and neurologic complication. And they emphasize that they're able to achieve a continuum of this adjustable correction, both in coronal and sagittal deformities. And that this procedure can be utilized in patient cohort who have more comorbidities, older age, that may not tolerate more invasive forms of osteotomies. And with this, I will pass on to Dr. Patel, who will present the last paper.
Can I ask a question?
Yes, sir.
So one question that I always have is there's a number of chats going on about the technique of how to perform this anterior release, and you identified the differentiated nature of resection versus attenuation, and also being cognizant of the osteoporosis or bone quality of a patient in terms of how you exactly afford this lower dosing. This is very nicely displayed by you. Could you differentiate the levels in which these are performed, as the fear, the worry about creating a potentially catastrophic vascular injury, especially at L4-5, is so much higher than if we do a junctional correction, such as you showed very nicely at T12, L1, or these kind of higher levels where the vessels have a little bit more play. So in other words, is there a level specificity to these assessments to accommodate for the risks of juxtaposition of the great vessels? Thank you.
So Jens, that's a really great question. And, I think that a lot of the time when we're planning on doing these procedures, the initial thought is that we're going to do a PSO And then what happens is during surgery, we attempt to not do the PSO and then convert to a intradiscal osteotomy / anterior column lengthening procedure. And prior to doing the PSO or prior to signing the patient up for a PSO, we always look at the anatomy of the vasculature and check to see whether there's laterality to it. And so very often higher up, you can find windows of opportunity, more so on the right or the left, depending upon the nature of the individual circumstances. And that's where we go a little bit more aggressively with our dilators. But our backup plan is always to not push our limits and to just do the standard procedure, which is the PSO, if we can't successfully release the ALL.
Thank you.
So we're now going to have Dr. Parantat Patel, one of our PGY1 residents interested in spine surgery. He's going to be presenting this paper from China. The authors of this paper actually came to visit at the spine section several years ago, and they gave some very nice talks on their experience with ankylosing spondylitis. And I think a lot of what we describe is perfectly demonstrated here. And this is particularly for those patients with calcified ALLs. I think, Parentop, I think you're still on mute.
All righty. Can everybody hear me now?
Yes.
Yes, we can hear you.
Just a second. Let me go ahead and share the screen one more time. Okay, can everybody hear me and see my screen as well?
Both okay.
Yes.
Excellent. All right. Good morning. Thank you for having us. The last paper, again, as Dr. Sansur mentioned, is this Chinese study that's now about 10 years old, but again, sort of highlights the key points that we wish to convey during this conference. A comparison between closing opening wedge osteotomies and closing wedge osteotomies on the sagittal balance in thoracolumbar kyphosis secondary to ankylosing spondylitis. Again, this was a single center retrospective case series using 64 ankylosing spondylitis patients, roughly split in half between the two surgical technique arms, all of them undergoing just a single level PSO with a minimum 2-year follow-up. And of course, the data was reviewed over approximately a 10-year span. The methods, initially, they had 98 patients that could have been candidates for the retrospective review. Surgeries performed all by a single surgeon over a 10-year period. However, only 64 patients actually fulfilled the inclusion criteria. The criteria were, number one, only a single level PSO. Of course, indications for the osteotomy were disturbed sagittal alignment, subjective inability to look straight ahead at the horizon for the patients, and any form of restriction to daily physical activity. And the second criteria was at least having a 2-year follow-up. There were certain exclusion criteria as well. Patients that had any form of previous spinal surgery were excluded, spinal fractures, and any history of pseudoarthrosis as well. And then importantly, again, hinting back at the vascular complications that could arise from this, patients with any scattered calcific deposits along the longitudinal wall of the aorta were also excluded, as of course that could result in a potentially devastating vascular complication. And then pseudoarthrosis, complicating ankylosing spondylitis, was also ruled out via X-rays, which they define as having an irregular discovertebral osteolysis with surrounding reactive sclerosis in a widened disc space. And here in table 1, we can see some of the demographic and characteristics of the two arms in the study. So the surgical technique, again, sort of a standard spinal frame, subperiosteal dissection to expose the posterior elements, and then placement of pedicle screws, at least 2 segments above and 2 segments below the planned osteotomy level. In the study, all the osteotomy levels were at either L1, L2, or L3. After the exposure was completed, the posterior elements were resected as demonstrated in figure A over here on the right. And then the surgery was performed at this point via 2 different ways. Number 1, which is demonstrated in figure B, was a wedge-shaped excision of the cancellous bone in the vertebral body, and sort of compression of the posterior wall of the vertebral body into this newly formed cavity. This was the closing wedge osteotomy technique. And then alternatively, the second technique, of course, the closing opening wedge osteotomy, was performed by exercising a larger excision of the cancellous bone, sort of almost in a more of a rectangular or in 3 dimensions, sort of a disc shape, with the borders of that excision being the superior and inferior end plates and the anterior cortex. And then providing lordosis up to the point where the anterior cortex was fractured. And of course, the correction of deformity was achieved by straightening out the spinal frame and elevating both the upper body and the lower body. After either one of these techniques was completed, the rods were placed and tightened in the standard fashion. Here's just an illustrative example that the paper describes of the closing opening wedge osteotomy. Again, here's a patient that you can see has pretty severe thoracolumbar kyphosis. And then we see some preoperative images here, followed by the performance of the actual surgery, and then long-term follow-up postoperative images. Seems to have achieved an excellent correction. Some of the results from the surgical perspective, at least, again, L1, L2, and L3 levels only. You can see the number of patients underwent either of the techniques at each of these levels. There was also some data regarding the mean OR time and the estimated blood loss as well. Again, the closing opening wedge osteotomy took on average, a little bit longer than just the closing wedge osteotomy did, as there was more bony work to be performed. And as a consequence of that, also a higher EBL. Another table here summarizing the complications from both of these techniques. Many of these are sort of minor complications, but there are 2 in particular to highlight. In the closing opening wedge osteotomy group, you can see that there was an intraoperative subluxation of the osteotomy site. To mitigate this risk, the authors did mention that they placed temporary rods on the contralateral side while they were working in the vertebral body. However, one patient did have this transient subluxation, which was quickly corrected, which did not result in any neurologic deficit postoperatively. And another patient also did experience some transient neurologic deficit in the closing wedge osteotomy group as well. Specifically, I believe it was a right foot drop, which was corrected with a more aggressive decompression. The patient at 6-month follow-up didn't have any issues with the right foot. Looking at some of the radiographic parameters as well. This is sort of a busy slide, but I've highlighted what I think was the most important. We can see here in the blue column, these are all significant statistically speaking, that both the closing wedge osteotomy and the closing opening wedge osteotomy were able to achieve significant corrections between the preoperative parameters and the postoperative parameters. And then if we were to look at the red boxes here, what we can see is across the various angles here, lumbar lordosis, the general kyphosis, sorry, the global kyphosis, we can see that the difference between the two groups, between the two surgical techniques, was statistically significant in that the closing opening wedge osteotomy did have greater correction in lumbar lordosis, for example, here. And then, of course, the clinical outcomes for these patients over the long run was measured using the Oswestry Disability Index, which is this index that scales patients' subjective level of disability from 0 to 50. Again, in the closing wedge osteotomy group, you can see an average reported score of approximately 25, and in the closing opening wedge osteotomy group, an average score of approximately 28. The comparison between these two was not statistically significant, and the range was quite varied. Certain limitations also for this study to be noted. Of course, it was retrospective and therefore not prospective or randomized. The decision to pursue the closing opening wedge osteotomy was made sort of in a stepwise fashion. If the desired correction was greater than 35 degrees, the closing opening wedge osteotomy was performed. Otherwise, a more limited closing wedge osteotomy would be performed. Also intraoperatively, should the amount of correction not have been sufficient per the intraop x-rays, the procedure was then switched over to a closing opening wedge osteotomy. And one of the limitations here is there was, in my opinion, probably a limited clinical outcome data here. Again, the only parameter that was assessed was the overall disability that patients experienced during long-term follow-up. And I did not note any sort of preoperative comparison with patient disability either. So the conclusions that the authors here had at the end of their paper was that the closing opening wedge osteotomy was an effective and safe choice for the treatment of thoracolumbar kyphosis in ankylosing spondylitis, and that this technique can achieve a large amount of correction at the osteotomy level.
Yeah, thanks very much, Parental. I want to just emphasize that in this study on the ankylosing spondylitis patients, it's critical to really look, and not just the ankylosing spondylitis patients, but to use that as a background example and to see that if the patient has had a long-standing fusion, as would be the case in someone with a history of ankylosing spondylitis, but even if the patient does not have ankylosing spondylitis, if they've had a long-standing history of a fusion and it looks like a very solid arthrodesis, the ALL is often calcified. And so when you're trying to release the ALL through what was described as the closing open wedge osteotomy, you basically are going to listen for an audible crack during the surgery. And it can sometimes happen inadvertently if you're doing a PSO. And if you do hear that audible crack, that means that you're essentially the only thing holding together the spine are the screws and the rods. And it becomes increasingly important to support that construct with additional fixation, such as bilateral double rods. So once, for an intradiscal osteotomy or for the ALL attenuation from the level of the disc base, in that scenario, it's not as destabilizing, and additional rods are probably optional. But when you do crack the ALL, I think it's very important to make sure that you add more strength to the posterior elements, especially since you're not going to be able to really support the anterior column very well with an interbody cage. Interestingly, the SWEET paper that Dr. Hahn presented, they get a complete ALL release, and you do place a cage in, but they really keep it very posterior so that there's end plate contact, and they really try to get like an interpositional fit of their cage, so there's room for improvement, with these techniques. I think the future is going to be to have cages that have anti-migration technologies, or to use endoscopes to facilitate visualization of the ALL.
So thank you for these papers. There are a number of things to point out, and I'm just following on the chat room. Let me start with something that I think is really important, and again, less pertinent maybe to the ankylosing spondylitis paper, but not excluded. Undoubtedly, these comprehensive posteriorly based osteotomies, whether they're shortening or an opening, certainly, procedure, have a very destabilizing effect. I mean, we basically completely disrupt the continuity, the mechanical continuity of the spine. And Dr. Ajoy Shetty, who I want to thank for his participation, he's been very active in the chat room, asks, how can we optimally assure fusions? This is obviously super important. Should we use quadruple rods? What kind of a device should we use? Do we have to have augmented bone healing things? And in the case of ankylosing spondylitis, my follow-up question is, are there long-term healing differences between opening and closing wedge osteotomies that the authors were able to elicit? So I'll shut up here, but thanks for addressing this important question.
Yeah, so, I think when you do have a total disruption of the ALL, quadruple rods are very important in providing that extra stability. With the ALL being disrupted, inner body, cage insertion may or may not be ideal. And so Sweet et al., they describe the use of an inner body cage to add additional support. My feeling on this is that if you can get good bone-on-bone contact, at least for the posterior 1/3 of the osteotomy, then I think an inner body cage is not 100% necessary. If you do see a large gap, even if the ALL has been disrupted, it may be advisable to try to put in a cage similar to how Sweet describes it, as long as compression can be performed across the interspace to get it to stay. So arthrodesis is very much at risk here. In the setting of an ankylosing spondylitis case, however, those patients naturally have the propensity to form bone. So it's relatively unlikely for a pseudoarthrosis to occur if you have bone-on-bone contact. Even if there is an absence of support in the very anterior most aspect of the anterior column. I think if you have a good posterior 1/3 of the vertebral body that's in contact, I think the risk for pseudoarthrosis in those patients is relatively limited.
Great point. And then one other question by Dr. Amin Haneen, who's a frequent flyer with us, and I welcome him also for his questions, is how can you kind of determine the number of levels necessary for fixation above and below to make sure that you pay credit to the bone density and the mechanical efforts that you're subjecting to your construct?
So very valid question. The Chinese paper from 2012, they advocated for at least 2 levels above and 2 levels below. that would be in the setting of a patient who has good bone quality. I think it's very possible that patients in this population have worse bone quality, and I would err on 3 to 4 levels above and below, and include pelvic fixation, especially if the osteotomy site is caudal.
Great, thank you. I think that's a super important factor. The other point is obviously going to the pelvis. If we're somewhere in the lumbar spine, is there any rule of thumb when you go to the pelvis and not just anchor in L5 and rely on that or S1?
So yeah, I think for any construct that is going to result in a long fusion, say for instance, if the fusion is above L2, I would say pelvic fixation becomes increasingly important. Even if you have a solid arthrodesis that goes from, let's say the patient had a previous L2 to S1 fusion and they have kyphosis and you needed a correction, I would advocate to place iliac screws in because I think the risk of SI joint failure or sacral fracture is high in the absence of pelvic fixation. So I do advocate for pelvic fixation when the constructs are long.
We have just 1 minute time left, so maybe Dr. Pasculian, vascular concerns about doing such an anterior column release have been cited several times. Any thoughts, any questions for Dr. Sansur and his great team at the University of Maryland as to how to minimize such risks?
That's a great question, Jens. And Charlie, that was terrific, going over the technique and the rod placement and everything. Fortunately, I haven't had any myself, but I've had a couple colleagues who've had some, whether it's a segmental or some venous bleeding, where usually it's hard to control those. I don't know what you think, Charlie, but the two colleagues I had, one was, I think, a segmental, and then the other one was, I think, venous. So they just kind of packed it off. But the trouble with doing this posteriorly is you really don't have access to, getting control of anything. So I think if the difficulties, if you do have a potentially serious vascular complication, I think you'd have to get IR. What do you think, Charlie?
Yeah, I agree. I mean, I think the take-home point is these procedures are not simple, and having access to a vascular team, both IR and regular vascular, is important. And so these procedures should probably be attempted at institutions and hospitals that have a very good support staff. So I knock on wood, I haven't had a large vascular injury during the performance of these types of procedures, but it's certainly possible, and we're on heightened alert for it. We're fortunate to have the latitude to have a very strong vascular team that has 24/7 availability.
Hey, Charlie, one last question. You're sort of wishy-washy on quad rods and what rods you use. So I'm going to pin you down. How many do you use? 3 rods, 4 rods, 5 rods? And then the fellows want to know, is it titanium? What's the diameter? 6/0?
So to eliminate the wish-washiness, I think 4 rods is advisable for a complete ALL release. If it's an ALL attenuation where you're just stretching the ALL, I think probably a double rod construct, I mean, just a standard single rod construct is okay if it feels relatively stable and you get a good interbody cage. You know, I may err on the side of adding a third rod, you know, just in that setting if I have some concerns about stability. But certainly for the you know, the ALL disruptions that are completely disrupted, a quad rod technique is necessary. And I err on the side of using a titanium alloy. I like the consistency of that metal.
Great. Thanks, Charlie.
Hey, we must come to a close. Maryland, you guys were great, really good topic. There's a lot of interest generated in the chat room, and I congratulate you on your work and this interest, and the discussion will be ongoing, but you clearly enhanced our understanding and appreciation of the complexity of this and the opportunities to make a big difference for patients with better, safer techniques. So thank you very much and have a great day and stay safe, everybody.
Thank you so much.
All right.